zone. We know the Latarjet works very well. This is a nice study on the military, and the recurrence rate was low, return to active duty almost 90%. So it's hard to really fight those kind of results. On the other hand, why do we do it every time? Well, it's not a panacea, as Mark just showed us. We know about long-term and short-term issues in terms of complications, OA, resorption, and oftentimes permanently distorted anatomy. So what if there's significant bipolar bone loss, but the soft tissue is preserved? Eden hip and that operation has been done now for over a century, and we think it's a targeted solution. So if you could reconstruct the glenoid with free bone block, you spare the subscap, you don't distort anatomy, it has a comparable success rate to the Latarjet in the literature, and the revision is certainly easier. And here's a nice study, one of the near ward rotor studies, an RCT level 1, and here basically you see no difference in clinical or radiographic outcome with the iliac crest versus a Latarjet. This is a Rachel Frank study. It's a head-to-head Latarjet versus DTA, and again, no difference in outcomes. So what are the indications for free bone block? Well, near-track bipolar bone loss, off-track bipolar bone loss, and in my hands more commonly it's from a failed arthroscopic Bankart where we know revision Bankarts simply aren't suitable. And the caveat here is soft tissue has to be intact. If not, you're certainly looking more at a Latarjet. If we look at graft choices for a free bone block, you can see there are all these issues, but I would tell you I use frozen DTA, so it's relatively inexpensive. It is available. There's no donor morbidity. There is a condyle surface, although I won't be worried about that because my graft will be extra-articular, and the congruence is there, as Matt has shown us in his studies. In terms of graft fixation techniques, I'm going to leave that a little bit to Dr. Lowe, who's going to inform us on what the current thought is in terms of what we use to fix it. But I have been using the double button technique for my free bone blocks. So let me show you. This is a right shoulder, young fellow who had a Bankart in Japan, a rugby player, failed in multiple recurrent dislocations. So we're coming around the 7 o'clock position, as all the speakers have told us. We pre-place our Bankart sutures. We then do a basically takedown of the labrum at nearly the base of the coracoid. We use a guide system based off the glenoid and use drilling through. That second hole you see is actually the 3 o'clock position. We take off the rotator interval. We simply pass these sutures through the glenoid, the transglenoid technique. The bone block comes in. This is actually a relatively simple and fairly quick procedure. And then we go and seat it. And this is going to be under the labrum. So you see the labrum is sitting on top of our bone block. We simply seat it, sits nicely, and then we're going to go ahead and fix it back with a second set of buttons, and then we do a Bankart on top of it so it's extra-articular, so I don't need self-viability in this situation. Now, Ivan Wong, who sort of fathered this to some degree using Matt's ideas, he had an outstanding study, and hard to want to do anything more than this for some of these tough cases. But he also showed here that, again, one subluxation. He also showed in a subsequent study, that screw fixation may be an issue. And here you can see when he used buttons, he had a 33% recurrence rate with a high level of resorption. When I heard this paper from Ivan, and because that's some research, I stopped doing this operation until my last patient had minimum 2-year follow-up. So we've done 18 patients, 17 were available for review. You can see we have an average of 3-year follow-up, mostly male, a little bit older, and we had about an 88% success rate. 2 of the 17 we considered apprehensive because they did have confidence, but they had not had another actual episode. You can see here that most were primary, and you'll see here that most were on track, and then that group, the 72%, most of those were revision failed Bankart cases or revision cases for a failed Bankart. Recurrence, again, we had 2 patients, no actual instability, but we considered them apprehensive, and we tried to be as severe as we could in terms of success rate and how we're actually doing. And then we looked at SANE scores, very pleased, pre and post-op SANE scores. And then we looked at CT. Now, it may be that 6 months isn't long enough, but we had this data, and you'll see here that we had healing in most. 2 had less than 100%, 1 was 50, and 1 was a non-union. And you see in terms of resorption, most were less than 25%. This was my non-union case at 6 months, not affected by this, interesting. So sometimes you can get Latarjets that don't heal that function just fine. Resorption on the far left, you see minimal resorption, in the middle less than 25, and on the right about a 50% remodeling in terms of resorption. This is a nice study out of Tylee, and Pat had a hand in this as well. And what you should know is when you do this free bone block, you have to do replissage because it really leads to the greatest resistance in translation. We use 2 tensioners, so when you put the first set of buttons down, leave the tensioner on, then do the second set, and I think it makes a difference. And then when we talk about fixation, again, Ian will tell us more about this, but I think we're starting to circle around, so to speak, to cerclage and button fixation. So in summary, arthroscopy-assisted glenoid reconstruction with free bone block is a preferred stabilization technique for glenoid bone loss with off-track lesions if the soft tissue remains robust, combined with a replissage and a Bankart. Frozen allograft is acceptable, especially with cost, because it's an extra articular procedure. The results are equal to the Latarjet, and when you can restore anatomy as a targeted therapy, I think it's always preferable. Thank you very much.